welcome to the deep dive. Today we're tackling a really core topic, disorders of motor function, drawing insights directly from Chapter 15 of Porth's Pathophysiology. When you just say, pick up a pen, it feels completely effortless. But underneath, there's this incredibly complex, multi-level system at work. It runs all the way from your brain down to your muscles. Our mission today is to map out that hierarchy, understand how it's supposed to function, and then really focus on what happens, what signs you see when parts of that system fail. It's like figuring out if the problem is the wiring, the power, or the motor itself.
That's a perfect analogy, and you have to start with the basics. Motor control, it is hierarchical, but it really hinges on two main types of neurons. You've got the upper motor neurons, the UMNs. They basically send the commands down from the brain. And then the lower motor neurons, LMNs. They're the final messengers, going out from the spinal cord or brain stem right to the muscle fibers.
So if either of those links breaks,
movement stops, or it becomes seriously impaired.
Right, so let's unpack that chain of command, thinking about that functional hierarchy the book describes. Down at the very base, you have the spinal cord.
Yep, basic reflexes, very fundamental stuff.
Then moving up, the brain stem. It seems to handle slightly more complex tasks.
Exactly. You've got medial pathways there, mostly for posture, keeping you upright. And then lateral pathways, more for goal-directed things, like reaching out to grab something accurately.
And then there are these other big players, the cerebellum and basal ganglia. They aren't directly in the main command line, are they?
No, they're more like high-level managers or processors. They loop signals back and forth with the cortex, constantly fine-tuning the movement, making it smooth, coordinating the timing.
So if they mess up, the movement might still happen, but it's clumsy or unwanted.
Precisely. Clumsy, uncoordinated, or you get involuntary movements popping up.
Okay, highest level then. The cerebral cortex. And that primary motor cortex, area 4. The motor strip.
Yeah.
That is that fascinating map, the motor homunculus.
It really does. And what's so striking about that homunculus, that little map, is the proportions.
Right. It's all distorted.
Hugely distorted. More than half of that entire cortical area is dedicated just to controlling the hands, the face, and speech.
Which tells you volumes about what's complex for us, neurologically speaking.
Yeah.
Dexterity and communication.
Exactly. Those are the really demanding motor tasks.
Okay, before we get into specific conditions, we need to nail down the difference between the two big descending pathways, pyramidal and extrapyramidal.
Absolutely crucial distinction for diagnosis. The pyramidal tracks, they're the direct pathway. Think fine, skilled, delicate movements.
And damage there, like from a stroke,
leads to a pretty predictable pattern. Increased muscle tone, what we call hypertonia, showing up as spasticity alongside paralysis or weakness.
But then the extrapyramidal system, it supports movement, right? So why does damage there, like we see in Parkinson's, cause things like rigidity and involuntary movements, not spastic paralysis? That seems counterintuitive.
That's a really important point to clarify. The extrapyramidal system isn't about direct commands as much as it's about modulating movement. It handles gross movements, background tone, and importantly, inhibiting unwanted movements.
Ah, okay.
So when parts of it, especially the basal ganglia, are damaged, you lose that modulation. Tone goes unregulated, leading to rigidity, and you lose the inhibition, so unwanted movements break through. It's a failure of control, of smoothing things out, not a failure to send the signal to move in the first place.
Got it. So that difference, UMN damage giving spasticity and paralysis versus basal ganglia damage giving rigidity and involuntary movements, that's a huge clue for figuring out where the problem lies. Now, let's go right down to the foundation, the motor unit.
Okay. The motor unit itself is simple in concept. It's one lower motor neuron, remember. Its cell body is in the spinal cord's ventral horn, and all the individual muscle fibers it connects to or innervates, they act together. Neuron fires, all those fibers contract. Simple as that.
So what happens clinically if that LMN itself is damaged? The muscle's connection is just cut off.
Completely cut off from the nervous system command. So you see that classic LMN picture.
Flaccid paralysis, right?
Yeah.
Weakness, zero tone or hypotonia. The muscle's just hangs there, and it starts to waste away pretty quickly. Denervation atrophy.
And the reflexes.
Gone or severely reduced. Hyperflexia or ariflexia.
And don't forget those other specific LMN signs, fasciculations.
Those visible twitches under the skin.
Exactly, little squirming movements. And then fibrillations, which you can't see. There are tiny, uncoordinated contractions of single muscle fibers, only picked up by an EMG test. Both of those signal that the muscle fibers are kind of irritable because they've lost their nerve supply.
Okay, so let's contrast that sharply with UMN damage.
Yeah.
The LMN is still there, still connected to the muscle.
Right, but its input from above, the regulation, is gone.
So instead of flaccid, you get the opposite. Hypertonia, increased tone, specifically spasticity. That resistance to movement that gets worse the faster you try to move the limb or at the end of the range of motion.
And hyperactive reflexes. You test the reflexes, and they're exaggerated. Sometimes you even see clonus.
That rhythmic shaking or beating of the foot or wrist after you stretch the muscle quickly.
That's the one. Classic UMN sign.
Okay, let's move from the nerve itself into the muscle structure. Muscular dystrophies.
Yes, these are genetic disorders causing progressive muscle breakdown. Duchenne muscular dystrophy, DMD, is the one we usually focus on first. It's X-linked, involves a defect in the dystrophin protein.
And dystrophin is like a structural anchor, linking the muscle's contraction machinery inside to the outside membrane.
Exactly. It provides mechanical stability during contraction. Without functional dystrophin, the muscle fibers just get damaged easily, they die off, necrosis sets in, and they get replaced.
Which leads to that devastating clinical picture. Weakness starting early, usually around the hips and shoulders first, often needing a wheelchair by, age 7 to 12?
Sadly, yes. And you also see that odd sign, pseudohypertrophy.
Right, the calves look big, almost muscular.
But it's false hypertrophy. Pseudo. The muscle tissue itself is gone, replaced by fat and connective tissue. So they look bulky, but they're actually very weak.
Okay, moving just one step up the chain to that critical connection point. The neuromuscular junction, or NMJ myasthenia gravis, MG, is the key disorder here.
MG is fundamentally an autoimmune problem. The body's own immune system attacks and destroys acetylcholine receptors, the AChRs, on the muscle side of the junction.
So the neurotransmitter, acetylcholine, gets released from the nerve ending, okay?
Yes, but there aren't enough receptors for it to bind to on the muscle fiber. The signal transmission gets weaker and weaker, especially with repeated firing.
And that directly explains the hallmark symptom. Muscle weakness that gets dramatically worse with sustained effort, fatigability.
Precisely. Often starts in the eye muscles because they're used so constantly. So you see ptosis, the drooping eyelids, or diplopia, double vision, as early signs.
Yeah, and treatment-wise, it makes sense. We use anticholinesterase drugs. They stop the breakdown of acetylcholine in the synapse.
Right, maximizing the chance that the ACH that is there will find one of the few remaining receptors.
And we also have to be careful clinically. Some drugs, like certain antibiotics, the aminoglycosides, can actually make MG worse because they interfere with ACH release from the nerve terminal itself.
Good point. Always important to check medications in MG patients.
Before we ascend fully into the CNS, maybe a quick word on localized nerve problems, mononeuropathies, like carpal tunnel.
Yeah, that's a great example of a localized peripheral nerve issue, essentially an LM-Naxon problem, but just in one spot. Carpal tunnel syndrome, CTS, is super common.
It's just compression of the median nerve right there on the wrist, isn't it?
Yeah.
Often from repetitive motion.
Exactly. And because the median nerve carries both sensory and motor fibers to parts of the hand, the symptoms are very specific to its distribution.
So pain, numbness, tingling. But only in the thumb, index finger, middle finger, and half of the ring finger.
Correct. And you can often provoke the symptoms with specific tests, like Tinel sign tapping over the nerve causes tingling, or Phelan's maneuver, flexing the wrist, makes the symptoms worse, confirms the localization.
Okay, good distinction. Now let's head back up into the central control systems, the ones responsible for coordination and grace, starting with the cerebellum.
The cerebellum. You can think of it as the master timer and coordinator for movement. It ensures everything happens smoothly and at the right moment.
So when it's damaged, things immediately get messy.
Very messy. You see ataxia, that clumsy, staggering, wide-based gait. People look almost drunk when they walk. And dysmetria.
Difficulty judging distance, like overshooting or undershooting when reaching for something.
Exactly. The accuracy is gone. And the tremor you see is very specific.
Tension tremor.
Right. No tremor when they're resting. But as soon as they try to do something precise, like touch their nose or grab that pen, the tremor starts and gets worse as they get closer to the target. It's a failure of fine-tuning during the action.
Which is a perfect setup to contrast with the basal ganglia disorders, especially Parkinson's disease, PD.
Absolutely. The basal ganglia are more involved in, let's say, automatic movements, background postural adjustments, initiating and stopping movement smoothly.
But Parkinson's is mainly known for slowness of movement. Bradykinesia. It's a hypokinetic disorder, right? Less movement. How does that fit with the basal ganglia's role?
It comes down to the specific neurotransmitter involved. In Parkinson's, there's progressive destruction of dopamine-producing neurons in a key part of the basal ganglia called the substantia nigra. And dopamine in this pathway acts sort of like an accelerator for movement. It helps initiate and smooth out motor commands. When you lose dopamine, you lose that facilitation. Everything becomes slow, difficult to get started.
Which leads directly to that classic Parkinson's triad. First, the tremor.
But it's a resting tremor, often that pill-rolling movement of the fingers. Noticeable when the hand is at rest, but it often disappears when the person deliberately moves or even when they sleep. Totally different from the cerebellar intention tremor.
Okay. Second, rigidity.
Yeah, increased muscle tone, but it's different from spasticity. It's often described as cogwheel rigidity, like a jerky resistance throughout the range of motion as you try to move the limb passively.
And third, and often the most disabling, bradykinesia.
That profound slowness, difficulty initiating movement, the shuffling gait with tiny steps, trouble turning, the mask-like facial expression because the small facial muscles are slow too, just a general poverty of spontaneous movement.
And logically, the main treatment targets that dopamine deficiency. Levodopa is still key, right? It's a dopamine precursor that can get into the brain.
Still the most effective drug for many. The goal is to boost the function of the remaining dopamine system.
All right, let's move to our final big category. Disorders affecting the upper motor neurons directly or causing widespread CNS issues, starting with amyotrophic lateral sclerosis, ALS.
ALS, also known as Lou Gehrig disease. It's particularly tragic because it's a double hit. It affects both UMNs and LMNs.
So you see signs of both. The LMN signs like muscle wasting, amyotrophy, and fasciculations, and the UMN signs like weakness, stiffness, spasticity, and hyperreflexia.
Exactly. Motor neurons in the spinal cord, brainstem, and even the cortex degenerate. But, and this is crucial, that the sensory systems, coordination, and intellect usually remain completely intact until the very late stages.
That's the devastating part. Patients are fully aware as they lose motor control.
Yes. And ultimately, it's fatal, typically due to respiratory muscle failure when the motor neurons controlling breathing are lost.
Next up, multiple sclerosis, MSCO.
Yeah.
This one is different. It's an immune attack, but specifically on myelin in the CNS.
Right. Key distinction. MS is only a central nervous system disease. The peripheral nerves, the elements themselves, are generally spared. It's the insulation, the myelin sheath, around the axons in the brain and spinal cord that's targeted.
And the immune system creates these lesions or plaques, hardened scar tissue where the myelin used to be.
Precisely. These demyelinated plaques disrupt nerve signal conduction. Think of it like stripping the insulation off electrical wires. The signals get slowed down, blocked, or short-circuited.
And because these plaques can form almost anywhere in the CNS white matter, optic nerves, brain, spinal cord, the symptoms are incredibly varied.
Highly variable. But common patterns include things like paresthesias, numbness or tingling, optic neuritis causing blurred vision or pain with eye movement, fatigue, and motor weakness. Often comes in episodes of relapse, followed by periods of remission.
Diagnosis relies on finding evidence of these lesions scattered in space and time, right? Often helped by MRI scans and checking the cerebrospinal fluid for signs of CNS-specific inflammation, like those oligonal bands.
Correct. Clinical picture plus supporting evidence.
Finally, let's touch on spinal cord injury, SCI, usually traumatic, causing damage to the cord itself.
Yes, and the immediate result is often spinal shock, a temporary complete shutdown of all function motor, sensory, reflexes, autonomic control below the level of the injury. It's transient, but profound.
But the longer-term issues arise from the injury itself and the secondary damage that follows bleeding, swelling, inflammation.
Exactly. And one of the most critical complications, especially for injuries high up in the thoracic or cervical cord, T6 and above, happens after spinal shock wears off. It's called autonomic dysreflexia.
This is a medical emergency, right?
Absolutely. It's triggered by something irritating happening below the level of injury, usually a full bladder or bowel. Because the spinal cord connection to the brain's autonomic control centers is broken, the sympathetic nervous system below the injury goes haywire.
Uncontrolled sympathetic discharge.
Massive vasoconstriction below the injury level, causing blood pressure to skyrocket dangerously high.
But the body tries to compensate.
Yes, the brain detects the high BP via sensors above the injury. It tries to slow the heart rate down via the vagus nerve, that's bradycardia, and cause vasodilation above the level of injury.
So the patient gets this weird picture. Severe headache, flushing, sweating above the lesion, but extreme high blood pressure below.
That's the classic picture. Recognizing it immediately and moving the trigger, like emptying the bladder, is critical to prevent stroke or other complications.
Wow. We've covered a huge amount of ground, from a single motor unit all the way up the hierarchy and back down.
And hopefully what's become clear is how the location of the problem really dictates everything you see clinically.
Absolutely. Knowing whether you should expect flaccidity and atrophy from an LMN issue or spasticity and hyperreflexia from a UMN problem.
Or distinguishing that Parkinson's resting tremor from a cerebellar intention tremor. That's the core skill, linking the underlying pathophysiology to what the patient is actually experiencing.
So as you absorb all this, here's something to think about moving forward. We've talked about the impact of diseases like ALS and Parkinson's. Given the limits of our current treatments for many of these conditions, where do you think the real breakthroughs might come from? Is it in things like regenerative medicine, maybe stem cells for ALS? Or is it more about technology, like refining deep brain stimulation for Parkinson's to better restore function in this incredibly intricate motor system? Thank you for joining us on this deep dive into motor function disorders. We really hope mapping out this system helps clarify these complex conditions for you.